Okay, let's dive in. Today, we're tackling two really serious complications you see with diabetes. Diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, HHS.
Right. And look, if you've ever tried to get your head around these, you know the information can be, well, kind of all over the place.
Exactly. Different protocols, confusing definitions. It's tough. So our mission here is to cut through that noise.
We've gone through some key sources, the Internet Book of Critical Care from Josh Farkas, EM cases, clinical guidelines.
To really pull out the essentials for you.
Yeah, we want to guide you through it, help you understand the why behind the protocols,
Yeah.
and maybe point out some common pitfalls our sources highlight, things to really watch out for.
Consider this your focus briefing on DKA and HHS. So let's start with DKA. Most people hear DKA and think sky-high blood sugar.
And that's often true, but it's more complicated. Some guidelines even say there aren't really definitive criteria that fit every single case.
Really, no definitive criteria.
Well, the core issue, the real problem in DKA, isn't just the sugar. It's the ketoacidosis, the buildup of acid.
Okay, so if high sugar isn't the absolute key, what is?
The gold standard, according to our sources, is checking the blood beta-hydroxybutyrate level. That's the main ketone body causing the acidosis.
Beta-hydroxybutyrate.
Yeah. A level over 3 mmol, that's pretty consistent with DKA. And if it's way up, like over 6, that's pointing towards severe DKA. It's much more direct than just looking at glucose.
What about those urine ketone strips? Are they useful at all?
They can be, but you have to be careful. They mostly detect acetoacetate, not the main one, beta-hydroxybutyrate.
Ah, okay.
So yeah, urine ketones might be strongly positive, like 2+ or more in DKA, but lots of things cause positive urine ketones, like just not eating for a while, starvation, ketoacidosis. That's actually pretty common.
So not very specific then?
Not really. A positive test raises suspicion, sure, but you really want that blood beta-hydroxybutyrate to confirm it and see how bad it is. And a negative urine test early on doesn't completely rule it out if you're suspicious.
Got it. Blood ketones are key. Okay, what about the anion gap, the whole mind the gap thing?
All right, the anion gap, you calculate it. Sodium minus chloride minus bicarb. It's basically looking for hidden acids in the blood. In DKA, the keto acids are those unmeasured negative charges, so the gap goes up, usually above 10 or 12.
And should we be correcting that gap for albumin or anything? I hear different things.
The sources we looked at were pretty clear. Don't overcomplicate it. Just use the basic formula. Nexial bicarb.
Keep it simple.
Exactly. Adding corrections just adds confusion. An elevated gap is a big clue for sure. But remember, it's not only DKA. Kidney failure patients often have a high gap too.
So context is key. Look at the ketones, the gap, the whole picture.
Precisely.
Okay, so how do we actually judge how severe the DKA is?
Severity is mostly about how acidic things are. So you look at the serum bicarbonate level and the pH.
Lower is worse.
Lower is worse, exactly. Very low bicarb, say less than 5, or really low pH, that's severe DKA. And those beta-hydroxybutyrate levels we talked about also line up. Higher levels mean more severe ketoacidosis.
So it all comes back to that lack of insulin leading to fat breakdown and acid production.
That's the core pathophysiology, yes. No insulin, body burns fat, makes ketones, causes acidosis.
Makes sense. So what typically kicks this whole process off? What are the triggers?
Usually it's some kind of physiological stress in someone with diabetes, or they just aren't getting enough insulin.
Yeah.
There's the classic mnemonic, the 5 I's.
The 5 I's.
Infection is probably the most common. Pneumonia, UTIs, things like that.
Okay.
Infarction, like a heart attack or stroke. Infant on board pregnancy can trigger it.
Yeah.
Indiscretion, basically, not taking their insulin properly. And just insulin deficiency itself, like maybe their pump failed or it's a new diagnosis.
And medications too, right? That seems more common now.
Definitely. SGLT2 inhibitors are a big one. They can sometimes cause DKA even without super high blood sugar. That's euglycemic DKA.
Oh, interesting.
Yeah. And steroids, some antipsychotics, those
Yeah.
can be triggers too.
Wow. So finding that trigger, it sounds like that's job number one.
Absolutely paramount. The sources really hammer this home. Missing the underlying cause,
Yeah.
that's often the cause of death.
Yikes.
Yeah. The DKA itself is dangerous, obviously, but it's often a sign of something else major going on that you have to find and treat. So good history, good physical exam are crucial.
What about symptoms? DKA patients often have bad abdominal pain, right? How do we sort that out?
That's really common, yeah. The ketoacidosis itself can cause pretty bad belly pain. The pearl here is, watch how the pain responds to treatment.
Okay.
If the pain is terrible but the DKA seems mild, or if the pain just doesn't get better as the acidosis improves with treatment.
Then you suspect something else is going on in there.
Exactly, like appendicitis, pancreatitis, something needing a closer look, maybe imaging.
What about confusion or altered mental status?
That can happen too, but it's usually tied to how concentrated the blood is, the serum osmolality. If it's really high, like 320, that can cause mental changes.
But if the osmolality isn't that high?
Then you need to think about a primary brain issue, stroke, infection, something else. And critically, if their mental status gets worse while you're treating them.
Uh-oh.
Yeah, you have to immediately think about cerebral edema. It's rare in adults, but devastating. Also, quick note, a high white blood cell count, leukocytosis, super common in DKA, just in stress. Doesn't automatically mean infection unless it's crazy high or they have a fever, other signs.
Okay, that clarifies a lot. Let's get into treatment. Where do we start?
Fluids, absolutely first priority, cornerstone. These patients are incredibly dehydrated.
Right, from all the urination because of the high sugar.
Exactly. Plus, maybe vomiting, not drinking. Yeah. Being that volume down actually makes insulin work less well.
Yeah.
So you've got to get volume back in them before or right as you start insulin.
How much fluid are we talking?
A lot up front, usually a few liters in the first couple of hours.
Yeah.
Big initial boluses, then ongoing maintenance fluids.
And the type of fluid? I always learned normal saline.
Ah, yes. Here's a really key point, maybe Pearl #1 from the sources. Try to avoid normal saline if you can.
Avoid normal saline. Why?
Because it's loaded with chloride. Giving lots of it can actually cause or worsen a different type of acidosis, a hyperchloremic metabolic acidosis.
So fixing one acid problem creates another.
Sort of, yeah. Even as the ketoacidosis gets better, the bicarb might stay low because the chloride load from the saline. This can mess things up, delay getting them off the insulin drip.
So what's the alternative?
Balanced crystalloids. Things like lactated ringers or plasmolite, they have a more normal electrolyte mix, less chloride. The thinking is they might help the acidosis resolve faster.
Okay, balanced fluids preferred over saline. Makes sense. Now, what happens when the fluids and insulin start bringing the glucose down?
Right. Once that glucose drops below a certain point, say around 250 or 300 milli-GDL, you have to add dextrose sugar back into their IV fluids.
Wait, add sugar back in?
Yes, because you need to keep the insulin going. The insulin's main job, remember, is to stop the ketone production and fix the acidosis.
Right, not just lower the glucose.
Exactly.
Yeah.
So as the glucose normalizes, you give IV dextrose to prevent them from getting hypoglycemic, while the insulin infusion continues doing its main job on the acidosis.
So you're basically feeding the insulin drip sugar so it can keep working on the ketones.
That's a good way to put it. You might switch to a fluid like D5-12NS
Right.
or add a separate bag of D10W. Allows you to keep that insulin running safely.
Okay, fluids are huge.
Yeah.
What about electrolytes? You mentioned potassium earlier.
Potassium is critical, maybe the most important electrolyte to manage carefully. Insulin pushes potassium into cells. So even if their initial level looks okay or even high sometimes because acidosis pushes it out of cells, their total body potassium is usually very low.
So the initial level can be misleading.
Very misleading. And if it's low to begin with, say under 3.3 millilem, you absolutely must hold the insulin.
Hold insulin if potassium is low.
Yes. Give aggressive potassium replacement first. Get that level up into a safer range, maybe aiming for high normal if their kidneys are okay. Then you can start or restart the insulin. And you check it frequently, like every 4 hours.
Wow, that's crucial. What about magnesium?
Also important. Check magnesium and replete it if it's low. Low magnesium makes it harder to fix low potassium and increases arrhythmia risk.
Okay, fluids, potassium, magnesium. Got it. Now, the insulin infusion itself, its main job is fixing the acid, using glucose as a marker.
Correct. Shut off ketone production, close that anion gap. That's the goal. There's usually a standard starting rate based on weight.
What about an initial insulin bolus? Do we do that?
Generally, no. Some sources mentioned it might be considered in really severe acidosis, but the IBCC source, for example, generally advises against it. It might increase hypoglycemia risk and doesn't seem to speed up gap closure much compared to just starting the infusion.
Okay, so infusion's the way to go. How do you adjust it?
Initially, you watch the glucose drop, aiming for a steady fall. But once you add dextrose to the fluids,
The glucose drop isn't the main guide anymore.
right, then the focus shifts. Is the anion gap closing? Is the acidosis resolving? If the gap isn't closing like you expect, even with good fluids, you might need to increase both the insulin rate and the dextrose infusion rate.
More insulin and more sugar.
Yeah, to keep driving that metabolic process and shut down ketone production without causing hypoglycemia.
And I remember seeing a strong recommendation about starting basal insulin early.
Yes, this is another key pearl. Start their long-acting basal insulin like glargine or datamir pretty early on. Don't wait until the DKA is totally resolved.
Why early?
Because it provides a safety net. It ensures they have some background insulin working when you eventually stop the IV drip. It smooths the transition, helps prevent the blood sugar from bouncing right back up. It might even get them out of the hospital sooner.
Makes sense. How much do you give?
Their full usual daily dose if they take basal insulin at home. If they're new to insulin, you calculate a weight-based dose, usually around 0.25 units per kilo per day.
And give the full dose, not like half.
Give the full dose. People get nervous. But remember, critical illness makes you more insulin resistant. They need that full basal coverage. Just make sure it's ordered correctly, usually once daily.
Okay, that's super practical advice. Let's talk about some tricky situations or complications. What about that non-anion gap acidosis, the NEGMA, that pops up during treatment?
Ah, yes, NEGMA. It's really common. As the ketoacidosis gets better, you might see the anion gap close, but the bicarbonate level stays stubbornly low.
Why does that happen?
A couple of reasons. They're losing potential bicarbonate, those keto acids in the urine, and, like we said, if you used a lot of normal saline or potassium chloride, that chloride load contributes too.
So the main DKA gap closes, but the bicarb is still too low to stop the insulin drip based on protocol criteria.
Exactly. Many protocols say you need the bicarb over, say, 18 or maybe even 20 before stopping insulin. So this emerging NGMA can keep you stuck.
Just what do you do?
You often actually do need to give IV bicarbonate at this stage. Not for the initial DKA, usually that's controversial, but specifically to treat this later angioedema, to get the serum bicarb up over that threshold so you can safely stop the insulin.
Okay, so bicarb has a role, but later on for the NEGMA, what if the main anion gap just refuses to close? Refractory DKA.
Good question. Time to troubleshoot. Are they really getting enough fluids? Is the insulin pump working? Is the IV line okay? Is the dose enough? Maybe they need more insulin and more dextrose.
Or is there something else going on?
That's the critical thought. Are you missing an underlying problem? Persistent infection. Something else driving acidosis, like lactic acidosis. You have to reevaluate everything. Check a lactate, check beta-hydroxybutyrate again. Search again for that hidden trigger.
Okay, let's shift to intubation. Pearl #3 was avoid intubation if possible. It's a trap. Why so dangerous?
It's incredibly risky. These patients are breathing really fast and deep small breathing to blow off the CO2 and compensate for their severe metabolic acidosis.
Right, trying to raise their pH.
Yes, exactly. Intubation and paralysis. That stops. They lose that vital compensation. If you can't perfectly match that rapid breathing on the ventilator instantly, their pH can plummet, crash, cardiac arrest.
Wow.
Plus, they're usually very dehydrated, so the drugs used for intubation can tank their blood pressure. And gastroparesis, slow stomach emptying, is common, so big risk of vomiting and aspiration during the procedure.
So definitely trying to avoid it. But if you absolutely have to intubate,
Resuscitate first. Fluids. Get their volume status as good as possible before you attempt it. Use drugs that are kinder to blood pressure. Maybe consider giving some bicarb right before if the acidosis is truly profound, like bicarb under 10, just for a bit of buffer.
but make sure they can blow off the CO2 it generates.
Right, and the second they're intubated,
Yeah.
hyperventilate them aggressively, high rate, high volumes on the vent. You have to mimic that compensation they were doing themselves.
What about non-invasive support like BiPAP?
Generally avoid BiPAP. That aspiration risk is just too high with the gastroparesis. High-flow nasal cannula might be a safer bet if they need some respiratory support, but don't meet intubation criteria.
Okay. Cerebral edema. You mentioned it earlier. Rare in adults, but scary.
Very rare. Much more a pediatric concern, but yes, scary. Highest risk seems to be younger adults, those starting extremely hyperosmolar, or patients whose sodium doesn't rise as expected during treatment.
Can we prevent it?
It's tricky. Old thinking, based on PEDS data, was about avoiding rapid fluid shifts or dropping glucose too quickly. But big recent pediatric studies haven't really borne that out clearly. The British guidelines even suggest maybe routine-specific precautions aren't needed in adults. Maybe be a bit more cautious in the highest risk folks. It's debated.
How do you recognize it if it happens?
You suspect it if a high-risk patient develops headache, worsening confusion, or starts vomiting during treatment. And if you suspect it, you treat immediately. Don't wait for a CT scan.
Treat with what?
Hypertonic fluids. Hypertonic saline, maybe hypertonic bicarb, something to rapidly pull fluid out of the brain. Get imaging later, but treat the suspicion fast.
Okay. Let's quickly cover euglycemic DKA, the one without the crazy high sugar.
Right, the tricky one. Glucose is under 250, sometimes nearly normal, but they have significant ketoacidosis, need a high index of suspicion.
What causes that?
Things like starvation, pregnancy, sometimes alcohol, but a really common cause now. Those SGLT2 inhibitor diabetes meds, they make you pee out glucose. So the sugar might not be high, but the lack of insulin effects still triggers ketone production.
So low sugar doesn't rule out DKA if they're on an SGLT2 inhibitor, for example. How's treatment different?
Key difference, you have to start IV dextrose right away from the beginning, along with the insulin and basal insulin. Since their sugar isn't high, you need to give them glucose immediately to prevent hypoglycemia while the insulin works in the ketones, and obviously stop the SGLT2 inhibitor.
Got it. DKA in a hemodialysis patient, that sounds like a curveball.
It really is. Their physiology is totally different. They don't have the massive fluid and potassium losses because they don't make much urine. They might even be fluid overloaded.
So the standard DKA protocol could be harmful?
Definitely. Giving big fluid boluses or lots of potassium could cause overload or dangerous hyperkalemia. You have to be much more conservative. Often, they just need insulin plus dextrose, maybe a more concentrated dextrose like D10W, to limit volume. And remember, their anion gap is always abnormal due to kidney failure.
So you can't use the gap to track resolution?
Not easily. You have to rely on blood beta-hydroxybutyrate levels, or at least see if their gap is trending back towards their baseline elevated gap.
Okay, be careful with fluids and potassium. Use blood ketones. Simpler question. Patient comes in with DKA, they use an insulin pump. What do you do?
Easy one. Disconnect the pump, take the infusion set out, treat them with standard IV insulin protocols for DKA, deal with restarting the pump later when they're stable.
Don't try to manage DKA with the pump.
No, just take it off and use the IV infusion.
And I think I saw something about using just subcutaneous insulin for DKA, the SQUID protocol.
Yes, that exists, but it's for very specific, carefully selected patients. Mild to moderate DKA only. No severe acidosis, no other critical illness, no pregnancy, not on SGLT2s, stable vital signs.
So not for your typical sick DKA patient?
Generally not.
Yeah.
It uses scheduled subcutaneous insulin shots instead of an IV drip. It's an option in the right setting, maybe if ICU resources are tight and the patient fits the criteria perfectly, but needs very close monitoring.
Okay. We've covered a ton of ground on treatment and complications. How do we finally know when it's actually over? When can we stop that insulin drip?
This is super important for preventing rebound DKA. You can't just stop it when the glucose looks good. You need to meet specific resolution criteria.
Okay, what are they?
The sources vary slightly, but the key elements are similar. The IBCC source lists 5 things that all need to be met.
All 5, okay.
1, ketoacidosis resolved. So anion gap closed, back to normal or near baseline, or beta-hydroxybutyrate level low, like 1.
Okay, gap closed.
2, serum bicarbonate is up. Ideally 18 millinam, maybe even aiming for 20.
Bicarb recovered.
3, they've received their full dose of basal insulin at least 2 hours ago. That overlap is crucial.
Basal on board. Check.
4, glucose is reasonably controlled, maybe 250. And 5, the patient is clinically better, awake, able to eat and drink.
Wow, that's quite a checklist.
It is, but hitting all those points, especially getting that bicarb up, really reduces the risk of them bouncing right back into DKA. EM cases give slightly simpler criteria, glucose 250 plus 2 out of 3, closed gap, pH 7.3 or bicarb 15.
Yeah.
But the principle is the same. Make sure the acidosis is truly fixed.
That bicarb target seems really key then.
It really does. Aiming for 18, even 20, gives you more buffer.
And then you switch them over to their regular subcutaneous insulin.
Yep. Stop the drip. Start or resume their mealtime insulin, maybe correction doses. Get them eating carbohydrates. Food plus insulin helps keep the ketones away.
Do you need to monitor them closely after stopping the drip?
Definitely monitor glucose. Maybe repeat electrolytes after, say, 6 hours, just to make sure the gap stays closed and everything's stable.
What if DKA comes back anyway? Why would that happen?
Could be several reasons. Stop the drip too soon, didn't meet all the criteria, didn't give enough basal insulin, or gave it too late relative to stopping the drip, patient didn't eat enough carbs, or you missed the underlying trigger and it's still active.
And if it recurs, what do you do?
Basically, restart the insulin infusion, make sure basal insulin is adequate, maybe increase it, double down on finding and treating the cause, and be aggressive about treating any NGMA to get that bicarb higher, because better bicarb actually helps insulin work better.
Okay, that's a really thorough look at DKA. Let's quickly contrast it with the other condition we mentioned, hyperosmolar hyperglycemic state, HHS.
Right, HHS. Often seen in older folks with type 2 diabetes. Can happen alongside DKA sometimes, or on its own. Both involve high sugar and dehydration, but the key difference.
Is the ketones.
Exactly. HHS typically lacks significant ketoacidosis, so DKA is kind of a triad. High glucose, acidosis ketones, HHS is more. Super high glucose, severe dehydration, and really high serum osmolality. The blood is extremely concentrated. Glucose levels can be way, way higher than in DKA sometimes.
So profound dehydration and hyperosmolarity are the main features, not acidosis.
Correct. And that severe hyperosmolarity is often what causes the major symptoms, especially altered mental status or even coma.
How does treatment compare?
Still involves fluids and insulin, but maybe even more emphasis on careful gradual fluid resuscitation and glucose lowering because of the extreme dehydration and osmolality, trying to avoid sudden shifts, similar to the concern about cerebral edema in DKA. And sources also mention being vigilant about blood clots, VTE prophylaxis, and pressure sores, because these patients are often very debilitated and immobile.
Got it. So similar principles, but different emphasis. Okay, let's try and boil this all down. What are the absolute must-know takeaways from this deep dive?
Okay, number 1, find the trigger. Always search for and treat the underlying cause. It's often the key to survival.
Right.
Number 2, DKA isn't just about sugar. It's about the acid. Focus on closing the gap, clearing the ketones.
Monitor the gap in ketones.
3, fluids are critical, and balanced fluids like LR or plasmolyte are generally preferred over normal saline to avoid that hyperchloremic acidosis.
Balanced fluids over saline. Check.
4, don't stop the insulin infusion too early. Make absolutely sure you meet all the resolution criteria, especially getting that bicarbonate level up.
Meet all criteria, especially bicarb.
And 5, be aware of the big pitfalls, especially avoid intubation, if at all possible. It's a trap.
Avoid intubation. Got it. Those are really clear points. You know, having this kind of deeper understanding, it feels like it moves you beyond just like following a recipe. You understand the why.
That's exactly the goal, to appreciate the physiology behind it. It shows how even a common disease like diabetes can lead to these incredibly complex critical illnesses that need really thoughtful management. And it also highlights how important it is to keep evaluating what we do, right? Things like which fluid to use or when exactly to start basal insulin. Constantly thinking about the physiology can lead to better care.
That's a great point to end on, that even with established protocols, there's always room to think critically, understand the physiology, and refine how we approach things based on that understanding and new evidence.
Absolutely. Never stop asking why.
Fantastic. Thank you so much for breaking all that down for us.
My pleasure. Happy to do it.
And thank you for joining us on this deep dive. We really hope you feel better equipped to navigate the complexities of DKA and HHS.